erythematosus in the sense of immunosuppressants. But this was a review for me as well from pharmacy school. So today we'll be talking about SLE. So for our objectives, at the end of this presentation, you should be able to identify signs and symptoms of SLE, describe complications of SLE, classify medications that are associated with drug-induced lupus erythematosus, as well as identify appropriate pharmacotherapy for a patient with SLE and determine appropriate counseling points and monitoring parameters for some of our pharmacotherapy agents. So the standard definition of SLE is a chronic autoimmune disease associated with the production of autoantibodies that can affect any organ within the body. There is no known cause. It is thought to be led by autoreactive B cell activation by our T cells, leading to immune complex deposition in our tissues, as well as activating an autoimmune cascade that may be limited to a single organ, as well as can potentially cause widespread systemic organ involvement. The organs most affected are our kidneys, our heart, our lungs, and our brain. And there's different cycles of SLE. So there can be active disease, remission, relapse, and progression. So some of our etiology, so it's most commonly seen in women ages 15 to 50. Women are about 10 times more at risk than our male patients. It is most common in some of our patients that are African, Asian, Arab, Chaldean, Hispanic, and Native American. These patients may have a more genetic predisposed risk, and the severity and flares can vary depending on the patient. It is quite a rare disease. It's estimated to affect about 0.05 to 0.1% of our US population. And about 1/2 of our SLE patients will manifest more severe complications of the disease, which we will talk about later on in our presentation. The survival rates depend on early diagnosis and treatment of the disease. However, the survival rate is about a little more than 90% for 10 years. So looking at some of our risk factors and triggers, so there is no known cause, but certain factors can make patients at a higher risk of developing SLE, as well as triggering flares in our disease. So first, looking at our genetic, epigenetic, and X chromosome linked factors. So patients with a first-degree relative with SLE are at a much higher risk of developing the disease. There has been shown HLA-DR2 and HLA-DR3 have the most consistent genetic risk factors for SLE that affect our major histocompatibility complex. There's greater than 100 gene variations in alleles that may contribute to SLE. Then thinking about some of our epigenetic components. So epigenetics is how the genes are expressed without affecting our underlying DNA composition. So this would be DNA methylation, modifications of our histones, or our microRNA. And then thinking about our X chromosome, there is rare X chromosome abnormalities, such as the TLR7 overexpression that may be linked to SLE. Next, moving to our hormone component. So both estrogen and progesterone, both endogenous and exogenous, are both linked with SLE. Estrogen stimulates our B cell maturation and antibody secretion in our normal immune system. And so our theoretical impact on SLE could be that estrogen has shown to increase an abundance of our progenitor B cells and can enhance the survival of splenic B cells, which then would promote the development of autoreactive B cells. So upregulating some of our autoreactive immunity. Estrogen can also have effects on our T cells as well. There's one study called the Selena study looking at the effect of oral contraceptives and the risk of SLE flares, and there was not shown to be a correlation. However, more research needs to be done in this topic, as well as some hormone replacement therapy has been shown to trigger SLE flares. So keeping in mind for our patients. Next, thinking about abnormalities in immune cells and cytokines. So our cytokines modulate both the innate and the adaptive immune responses. Both a defect and an excess of cytokine production, as well as abnormal responsiveness of immune cells to cytokines, can favor the development of immune-related disease. Are thinking about our T cells, they can drive inflammation as well as induce our B cells to generate autoantibodies. So any dysregulation to those can promote SLE, and as well as we have spoken a little bit about our B cells contributing through autoantibody production. Next, thinking about our environmental factors. So UV light exposure or skin damage is very common in SLE patients, as well as being exposed to pesticides, cigarette smoke, air pollution, heavy metals, as well as exposure to some infections, especially Epstein-Barr virus or EBV, could promote immune stimulation, which could cause an activation or reactivation of SLE. And then lastly, thinking about our medications, which we will talk about later in our presentation when we talk about drug-induced. So kind of a brief overview of the pathophysiology. So as we talked about, we have our predisposing factors that can lead to cell damage, then leading to our abnormal immune response. So an abnormal immune response could be a loss of self-tolerance to one's own self-antigens. Our T and B lymphocyte activation and signaling is altered. An increased number of B cells and plasma cells produce autoantibodies. Apoptosis may occur when the debris and nuclear material would be improperly cleared. That material can then lead to autoantibody immune complexes. So our autoantibodies are binding to that nuclear material and then depositing in our tissues. Our complement cascade is triggered further, giving us more inflammation and injury, then activating our innate immune system, triggered by our antibody antigen complexes. So we're getting lots of inflammation, which then can then lead to end organ damage. For presentation of our SLE, it's very widespread. As you can see, most commonly patients present with fatigue or depression, as well as joint pain. Patients may also have headache, nausea, and abdominal pain, as well as photosensitivity and weight loss. Our signs include the rash or a malar butterfly or discoid rash, which our next slide will show you some pictures of those, as well as fever, oral and nasal ulcers, renal dysfunction, seizure, psychosis, pleuritis, pericarditis, anemia, leukopenia, thrombocytopenia, as well as Raynaud's phenomenon. So as you can see, the presentation is very nondescript. So we'll talk about some of the things that can help differentiate lupus from some of our other disease states that may present in this way. So thinking about some of our cutaneous presentation. So on this first column, we have discoid lupus, or sometimes it's referred to as chronic cutaneous lupus erythematosus, or CCLE. It's the most common of the CCLE presentations. Our malar, or our butterfly rash, is presenting as our acute cutaneous lupus, or ACLE. And so that's our middle column, where you have kind of the redness going across the face, kind of looking like a butterfly. I think I'm sorry, but stop sharing. Thanks. And then on our last column, we have our subacute cutaneous presentation, which these can present at any time throughout the course, and some are scarring versus some are not. So next we have our classification. So in 2019, the European League Against Rheumatism, as well as the American College of Rheumatology, classification for SLE, released guidelines to try to help streamline kind of where people are in their SLE, as well as classifying it and distinguishing it from other disease states. So firstly, our patients would have a positive anti-nuclear antibody. About 95% of all SLE patients have that. And then we have kind of broken down into two categories, our clinical and our immunological classifications. So for renal, patients may have proteinuria as well as positive abnormalities on a kidney biopsy. For hematologic, patients may have leukopenia, thrombocytopenia, as well as autoimmune hemolysis. For neuropsychiatric, patients can present with delirium, psychosis, or seizure. For mucocutaneous, patients may have non-scarring alopecia, oral ulcers, subacute cutaneous, or discoid lupus, kind of some of the presentation that we previously saw. For our serosal presentation, pleural or pericardial effusion that could lead to pericarditis, as well as musculoskeletal or joint involvement and constitutional patients presenting with fever. Looking at some of our immunological presentation, so our patients may have antiphospholipid antibodies as well as complement antibodies, low C3 and or low C4, as well as SLE-specific antibodies of anti-double-stranded DNA antibody or an anti-SNP antibody. So now thinking about our drug-induced lupus. So here are the most common drugs that you may see that could induce lupus. And so it represents about 6 to 12% of all lupus cases. It may take a few weeks to several months to develop drug-induced lupus after starting one of these medications. Out of these ones that are listed, procainamide and hydralazine have the highest incidence and may be caused by DNA methylation, which is a callback to one of our risk factors of epigenetics. Usually the treatment for drug-induced lupus is our discontinuation of the drug, which usually resolves within weeks. For some patients, it may be months. And again, discontinuing the drug may help or will help, get rid of the lupus symptoms, but if patients are having bothersome symptoms, they can use NSAIDs or low-dose steroids. And on the bottom here is just from the NAPLEX book. As you guys are preparing for the NAPLEX in the next couple of years, there's a mnemonic to help you remember which drugs are associated. That brings us to our first learning question. So there might be more than one answer. Which drug or drugs are associated with drug-induced lupus? Yes, that's right. Everything but ACE inhibitor. And we'll talk about a little bit later. ACE inhibitors might help in some of our lupus disease states. So thinking about some of the complications, so we do want to treat lupus early within diagnosis. However, if we start to get organ involvement, these are some of the complications that may arise. So lupus nephritis, 50 to 60% of SLE patients develop that within 10 years, and 15 to 20% of them progress to end-stage renal disease. Some of our neurocognitive symptoms include ischemic stroke, seizures, cognitive dysfunction, mood disorders, and movement disorders. Some of our cerebrovascular disease include hypertension, accelerated atherosclerosis, pericarditis, and myocarditis. And for coagulopathy, patients may develop antiphospholipid syndrome. In pregnancy, it can be a comorbidity, as well as patients may develop a DVT-PE. And I do want to point out here, we'll not be addressing some of these directly with treatment, but when we're thinking about treatment for SLE patients that are having some of these complications, we do there are their own guidelines kind of breaking down each of these topics that talk about what treatment might be right if their patients are having some of these complications. So thinking about some of our treatment considerations. So our goals of therapy are to prevent disease flares and progression to our other organs. First and foremost, we want to decrease disease activity. So kind of some of these things that may harm patients' quality of life, decreasing those activities, maintain remission, so the amount of time that patients are disease-free, reduce the use of systemic steroids if possible. I am quite sure that you guys have talked about steroids in some of your other lectures and know the risks of prolonged steroid courses. So as we'll talk about, it is kind of the backbone of treatment, but we do want to reduce the use of systemic steroids as much as possible, as well as improve patient quality of life. So first, thinking about some of our non-pharmacotherapy options to treat some of these disease states. So patients can have comorbidities as well that may increase flares. So managing our comorbidities of hypertension, hyperlipidemia, osteoporosis, depression, managing those as to not worsen some of the effects of SLE, thinking about exercise and weight control to help with some of our musculoskeletal factors of SLE, as well as smoking cessation, as that is a risk factor for flares and disease progression, sun avoidance, and protection. So sun protection is very important, especially patients that are having some of those cutaneous reactions, as we saw in those pictures. It's very important to protect ourselves. So sun protection, including hats, long sleeves, staying out of the sun in the most active times of day, using sunscreen and reapplying sunscreen after 2 hours, as well as immunizations, which we will talk about kind of later on in this presentation. So just an overview of some of our treatment options. So we have for our mild aspirin, which is FDA approved, as well as some of our chronic therapy. We have our oral and topical steroids, hydroxychloroquine, cyclophosphamide, mycophenolate, cyclosporin, voclosporin, and some of our biologic agents. This list is not all inclusive, but And we will not be talking about all of these today, as they might be a review of some of your other lectures. So thinking about our medication selection, so hydroxychloroquine is kind of the backbone of our treatment for our SLE patients. We can add glucocorticoids and NSAIDs as needed. And then kind of if our SLE flares and symptoms are not controlled, moving then to some of our immunosuppressant agents, so methotrexate, azathioprine, mycophenolate, as well as our biologic agents. And then if we're really having refractory disease, we can add IV cyclophosphamide plus or minus rituximab. So this is a nice guideline from our EULR showing some of the treatment considerations. So this is for non-renal SLE. As I mentioned before, there is specific renal guidelines, so the treatment looks slightly different. But again, hydroxychloroquine is our backbone. So for all patients, unless it's contraindicated, and then kind of moving across from mild to moderate disease. So there is a SLE disease index. It's a score of 24, and so you want the lowest possible score. It composes some of our clinical signs as well as some lab values. So patients with mild disease have some just constitutional symptoms, so fever as well as mild arthritis, rash that's less than 9% of their body surface area, so not covering a lot of their body, as well as lower platelet count, and then a SLE disease index of less than or equal to 6. So thinking about for mild, you might just need hydroxychloroquine as your first line, and then some steroids as needed for flares. Again, tapering to the lowest possible, as well as discontinuing. Our guidelines, or the guidelines, recommend less than 5 milligrams per day to try to limit some of those long-term side effects. Our moderate disease, kind of a bigger rash, more platelet abnormalities, a disease index score of higher, so 7 to 12, and then thinking about our severe disease, so we're having kind of major organ-threatening disease, and that's when we start moving into some of our past our biologic agents into our cyclophosphamide rituximab treatment, as well as they list some of our general measures of preventing as well. So kind of for SLE, the guide to therapy is to hand in hand kind of use some of our pharmacologic agents as well as a lot of our non-pharmacotherapy for treatment. So as I mentioned, hydroxychloroquine is our backbone. This should be a review from your previous lectures. It's an anti-malarial agent that can suppress our activation of toll-like receptors. I've listed the dose here. It is an oral agent. Some of its main side effects are GI, skin, and retinal toxicity. So sometimes hydroxychloroquine can cause what's called bullseye maculopathy. And so I don't know that I can get, I don't think I can get that line. But if you look all the way over there, there is a white ring kind of around that dark circle looking like a bullseye. So that is our retinal toxicity. So for monitoring, we want to monitor for side effects, especially encouraging our patients to get an annual eye exam. Some clinical pearls when using hydroxychloroquine. So you may have 2 to 8 weeks to see the full therapeutic effect. The advantages, it doesn't have any myelosuppressive effects or toxicities, requiring less monitoring than some of our other agents might have. However, the efficacy might decrease over time, and it does have anti-inflammatory, immunomodulator, and antithrombotic properties, which might help with some of the side effects that you might see in SLE. So just briefly touching on our glucocorticoids. So they can be used as a bridging therapy for flare management or maintenance therapy. As we talked about, you want to limit to less than 5 milligrams per day. That is prednisone equivalent. If you can, as well as trying to discontinue. Sometimes if the flare is significant enough, patients may receive IV methylprednisolone for flares. It can be used topically or systemically. It has a rapid onset, and our pulse dosing is used to treat flares or acute organ threatening disease, and then taper to our lowest effective dose. So briefly touching on some of our biologic agents. So the first two, belimumab and anifrolumab, are both FDA approved for SLE, and then we have rituximab as our kind of rescue treatment for our most severe disease. So thinking about belimumab or Benlysta, it helps reduce our activity of our B-cell mediated immunity by inhibiting the binding of soluble human B lymphocyte or BLyS to receptors on our B cells. I've provided the dosing here. You don't need to know that. That's mostly for reference. And there is slightly different dosing for lupus nephritis. Some adverse effects. We have GI symptoms as well as some CNS symptoms. Because this is a kind of B cell agent, we want to monitor for infection, as well as patients may have infusion reactions. So pre-medications are recommended prior to infusion, and it's not recommended for use with other B cell targeted therapies. Next, our next safanillo is another one of our biologic agents. It reduces inflammatory and immunologic processes by inhibiting the biologic activity of type 1 interferon receptors. Again, has some infection as well as malignant neoplasm and respiratory adverse effects. And we would still want to monitor for infection and use pre-meds for our infusion-related reactions. Thinking about our patients that have active skin disease, so our patients are receiving hydroxychloroquine as well as topical agents, which could be glucocorticoids or our calcineurin inhibitors as a topical, as well as systemic glucocorticoids if needed. If patients are still having severe skin kind of component, we can add some of our other agents as a second line. Thinking about Dr. Moore's presentation, she talked about some of the topical corticosteroid potency. So I've listed it here as kind of a reference for low, medium, and very high. Again, kind of trying to limit our duration as much as possible to just the flare, as well as we go up in potency of corticosteroids, the kind of maximum recommended duration goes down. So the amount of time that you can use some of these agents in our very high category is much less than our low potency topics. So next, thinking about our special populations. So in our pregnant population, it is recommended to conceive after 6 months of disease inactivity, as well as discontinue teratogenic drugs 3 months prior to conception. The flare rate in pregnancy for SLE is 45 to 70%, so it's quite high, and it can cause some comorbidities as well in our pregnant population. So trying to get our disease managed prior to family planning for our patients. Thinking about what recommended medications as well as medications to avoid. So hydroxychloroquine remains our first line, as well as our oral glucocorticoids, azathioprine and CNIs. Some of our medications that we'll be avoiding, cyclophosphamide, mycophenolate, methotrexate, and NSAIDs. So kind of as pharmacists, we can work to manage some of these medications or switching patients their therapies if they are wanting to do some family planning. Thinking about SLE and antiphospholipid syndrome. So for primary prevention, as we talked about, hydroxychloroquine may have some antithrombotic properties, as well as patients with high-risk antiphospholipid antibodies may receive aspirin 81 milligrams daily, as well as secondary prevention. So our patients that have SLE and have had DVTs or PEs would receive warfarin. Yeah, oh, sorry.
For patients who are not using contraceptives at all, what medication would they give?
So the question for people online was for patients not using oral contraceptives, what medication would we give them? So thinking about our first line is hydroxychloroquine, and that would be safe for our pregnant patients. But I think just open communication with our patients that are of a childbearing age is important too, to kind of talk about the risks of some of these medications in pregnancy. Um, what should happen if they're not using protection. And talking about the risks and then kind of addressing that as it comes up. But hydroxychloroquine would be a good medication. However, if patients are using a different medication that may be teratogenic, but they're a childbearing age, it's not something that we need to switch them. I think patients just need to be counseled on the risks if they're not going to use oral contraceptives or a different contraceptive method. So thinking about some of our vaccinations, so staying up to vaccinations, especially for COVID-19, varicella, influenza, HPV, and pneumonia, all of these have been shown to have, all of these disease states have been shown to have negative effects on SLE. So as pharmacists, we can help prevent or help promote vaccine education and making sure our patients are up to date on their vaccines, which may help prevent complications as well as progression of our SLE, as well as any patients that are receiving B-cell depleting therapies, trying to give their live vaccines at least 2 weeks prior to any of those agents. So working to kind of boost kind of patients' immune systems prior to giving some of those. So we can work as pharmacists too to plan out some of that. So you guys can just shout it out. What medication is first line for patients? Great. That's the main takeaway. So thinking about our key concepts. So SLE is an autoimmune disease, like an unknown cause. It can be triggered by a number of factors that we've kind of gone over. So environmental, some genetic, but thinking about our environmental factors, some of those are modifiable for our patients, as well as lifestyle modifications are recommended as part of their treatment to help improve patient quality of life, as well as hydroxychloroquine is our first line agent, and therapy should be individualized to the patient. So as I mentioned, some of these complications that you might have, there is set guidelines for those that have slightly different kind of treatment recommendations, as well as we've discussed our special population of pregnancy, we can kind of change the therapy as well. So here's a nice resource that you guys have access to. And that is my presentation. I will take any questions at this. Great.
All right. Well, that is it. Like I said, if you guys have any questions regarding